Right. Thank you for the kind introduction. Uh, in the next few couple of minutes, I will be talking to you on the management of childhood diarrhea in primary care. In this presentation, I would like to start my presentation uh, with one of the slides in the latter part, which is the summary. My summary is actually this is a presentation. No need to do a separate lecture because everybody know the management of diarrhea, which is hydration and electrolyte imbalance, management of electrolyte imbalance, zinc supplements, probiotics and prebiotics. The problem is the frequent regimes of diarrhea are these. These prescriptions I have been collected from over the time. These consist of ORS, domperidone, cefalexin, cefixime, ondansetron, probiotics with zinc, probiotics plus zinc, ciprofloxacin, cefalexin, sometimes omeprazole, simethicone, famotidine, loperamide. So there is a huge difference. So my objective would be to fill the gap between the knowledge and the practice. I think the understanding of the management of childhood acute diarrhea would fill the gap because just knowledge alone won't is not enough to make the practice. So education is knowledge, skills, and attitudes. These are the components. But I have slightly changed it. Knowledge with understanding, skills, and attitudes make practice with educated behavior. So, before starting this presentation, what is diarrhea? Is it stool frequency, stool consistency, stool volume, or composition related to this disease? I would like to show some pictures because pictures always make presentation interesting. However, the diarrhea pictures may not be interesting to you. So these are some samples of stool, different volumes, different consistency, different composition. The first picture on this side, this is goat poo, this is rabbit poo, this is pigeon drop. Who has got diarrhea? I think none of them. Because diarrhea is not, because there are so many definitions. But diarrhea to me is different to diarrhea to you. This acute change in increased frequency, increase the more liquid consistency, increased volume, and sometimes change in composition like blood and mucus. It is the stool habit is different from person to person. Though these pictures are not present, you can make anything present. This is also a picture of stool. This is a poo of a quack. The Copic luwak is also known as civet coffee. It's a coffee that consists of partially digested coffee cherries which have been eaten and defecated by Asian palm civet. The cherries are fermented as they pass through a civet intestine. After being defecated with a fecal matter, they collected and make coffee. This is the most expensive coffee in the world. It sometimes a cup may be as expensive as 100 USD and 1 kilo may be as expensive as 1000 USD. The second most expensive coffee in the world is elephant poo coffee. This is about $50 per cup, and so anyway, that's different. So, what are the causes of diarrhea? So, it can be infection, inflammation, metabolic, or toxic. But I am going to concentrate here on acute diarrhea in children. Those are mainly infective. Most of them are virus and bacteria and parasites like amoeba and trichoris, and fungus can cause diarrhea. But most of the diarrhea in children are viral and bacterial diarrhea. Out of that also, most of the diarrhea is viruses. There are a phenomenon known as antibiotic associated diarrhea also. Sometimes this diarrhea is a direct effect of antibiotic like ampicillin and amoxicillin causing diarrhea, and sometimes it is due to alternation of bowel flora like in cephalosporins, and sometimes it is due to pseudomembranous colitis due to antibiotics like clindamycin. So antibiotic is a more of a cause of diarrhea than a treatment of diarrhea. So complications, not very much, dehydration and electrolyte imbalance and acidosis, but still the diarrhea is the second cause of death in children in the world. So these two complications is enough to kill a child. So ORS made a big difference in the morbidity and mortality of diarrhea. That is why the ORS, the composition of ORS got Nobel Prize. So what are the treatment targets? Treatment targets are correction of complications, that is rehydration and correction of electrolyte and acidosis imbalance, and reduction of duration, severity, spread, and complications. So how do we do rehydration? We can do IV rehydration with simple normal saline. No any other IV solutions, no Hartmann, no Rigalactate, nothing. Simple. Now current guidelines only normal saline, but very rarely necessary. Very rarely necessary. Indications are shock, drowsiness, and vomiting. Shock, drowsiness, and vomiting. Otherwise, we can treat with ORS. How do we assess dehydration? This dehydration is assessed based on the percentage of hydration. If dehydration is less than 10%, 10% or more than 10%. There are various dehydration types. The old one is mild, moderate, severe. Then the WHO classification came. No dehydration, some dehydration, severe dehydration. But in current classification, in the latest version of illustrated textbook of pediatrics shows no dehydration, clinical dehydration, no clinical dehydration, clinical dehydration, shock. So shock, you know how to treat. Clinical dehydration, if patient can tolerate ORS, give ORS. On demand, not on regimes, on demand. If child is not tolerating ORS, that is drowsiness, vomiting, give IV. Otherwise, no indication. So no clinical dehydration, shock. This is the current classification, stage. So ORS, you know it, the Jeevani, there are 200 ml sachet, 1000 ml sachet, and sometimes liquids also available. ORS is given on demand. No need to give ORS by force. The dehydrated children are having thirst. They ask to it. No need. If any child need forceful dehydration or ORS means that there is no diarrhea. If patient is conscious enough, no need to give forceful giving. They always eagerly ask for even salt water, anything they ask if there is dehydration. So there are glucose-based ORS, that is the commonly available one. There are sucrose-based ORS, not commonly available now. There are rice-based ORS, those usually they are homemade, that is rice, the pedihal candle. And no preparation is superior to other. No preparation is superior to other. The previous ORS was targeted for cholera management. Now cholera is hardly seen. So that now there are low salt, low sodium formulas which is used in given. Probiotics and zinc known to reduce diarrhea, reduce duration of diarrhea and severity of diarrhea, but you have to give with caution in immunocompromised patients. Probiotics, prebiotics. Probiotics are helpful bacteria. These are available in some of our foods. Prebiotics are substances that increase the growth of probiotics. The commercially available probiotics are available in liquids, capsules, tablets, and sachets as powders. And the commercially available prebiotics are available in phospha and gosa, fructooligosaccharides, and galactooligosaccharides. But in day-to-day home food like banana, honey and treacle, garlic, onion, gherkin, sweet potato, cheese. Those are some of apple. Those are some of the food which contain most of the fibers are prebiotics. And when we take prebiotics and probiotics together, it is known as symbiotics. The best symbiotic combination in our country is the treacle and curd. The treacle and honey contain prebiotics and curd has probiotics. Very good combination, natural food. Zinc supplements restores intestinal barrier integrity. It is known to reduce duration and severity. The dose is 20 ml per kg, 20 ml milligram per day, and children it is 10 milligram per day. You can give it in divided doses if necessary. It prevents diarrhea in the following even 2 to 3 months. It prevents next 2 to 3 months diarrhea as well. The preparation which contain highest element of zinc is zinc sulfate. Probiotic with added zinc. You may have seen some sachets commercially available. Probiotic plus zinc. I think better to give it separately because zinc sulfate is a salt, probiotic is bacteria. How do you keep salt and bacteria together? So always better to give it separately. And probiotics with antibiotics. You may have seen the previous prescriptions. They have given antibiotics with probiotics. Yes, that can be done for inflammatory bowel disease, and sometimes when you give antibiotics, you can give probiotics to treat it, but not for diarrhea. Diarrhea, if you give prebiotic antibiotic, the prebiotics is a probiotic is will be killed by antibiotic. So no point giving both together. Antidiarrheal medications not indicated, like drugs like loperamide, not indicated in the management of childhood diarrhea. What are the indications of diarrhea? Very few, and these indications you have to give. Those are cholera, salmonella, amoeba, and campylobacter. You have to give antibiotic, but it is not common in your primary care setup. Primary care set all diarrheas are viral diarrheas and self-limiting bacterial diarrheas. Shigellosis. Shigellosis causes blood and mucus diarrhea. It is Shiga toxin mediated. The complications are hemolytic uremic syndrome and encephalopathy. Usually self-limiting. So what are the some? But we have seen that people are giving antibiotic to shigellosis like furosolidone, ciprofloxacin, efixim, and ceftriaxone. Yes, you have give it for septicemia of shigellosis, not Shigella diarrhea. If you give Shigella diarrhea antibiotics, do not reduce the severity, do not reduce the duration. It only reduce the spread. So I don't know any person who is going to take antibiotic to spread Shigella. So I think better to get hygienic measures to reduce spread and not giving antibiotic. And antibiotics may increase complications by lysing the cell, increasing the release of Shiga toxin, then increasing the risk of HUS and hemolytic uremic syndrome and encephalopathy. So the common blood and mucus diarrhea are shigellosis, E. coli, and amoeba diarrhea, and inflammatory bowel disease. But when you get blood and mucus diarrhea, always exclude intersusception. Because intersusception presents as blood and mucus diarrhea, it is a surgical emergency. So food poisoning and food intolerance also causing significant diarrhea in primary care. Food poisoning are caused by salmonella, which is usually by poultry products. Staphylococcus usually the food poisoning common in by potato-related drugs. Potato, it can cause vomiting predominant and diarrhea predominant food poisoning. Bacillus cereus causes they are in rice, and listeria in old cheese, and clostridium in the canned food. Canned food can produce have anaerobic environment. The clostridia grows there. And there are food intolerance also causes diarrhea, lactose intolerance and comic intolerance. Lactose intolerance is also a common condition in children. So it is due to lactase deficiency. It can be congenital or acquired. Usual lactose intolerance, what we see in the word is acquired lactose intolerance due to intestinal wall damage causing reduced lactase enzyme, and investigation is stool reducing substance. You should know how to collect stored reduced substance stool. You have to ask the patient to be kept on a polythene and let the past diarrhea stool to collect it with the syringe, because you need the liquid stool to do the reduced substance. Otherwise, don't collect the stool from the nappies and squeeze it and then squeeze to get the liquid, and it is not successful. The treatment is avoid lactose containing food and lactose free formula. So now I think you will be clear the summary. The diarrhea management is hydration and electrolytes, zinc, probiotics and prebiotic. You know there are no indication for this kind of prescriptions anymore. There are no indications. I think your knowledge, I try to fill the gap between knowledge and understanding. One year I saw that there was a question in the final MBBS exam regarding a 2-year-old child presented with a history of profuse watery diarrhea, 3 days, and this is simple watery diarrhea. And they have asked outline the key aspect of management and the 5 complications, and list the concentration in the ORS. And then another again they have asked the patient discharge home and again came with diarrhea, and what is the most likely, it is lactose intolerance, and how to manage. The students, I think, very few students scored over 40 marks, and very few students scored over 40 marks. Extremely rare. Very few students took above 80 marks as well. I remember one student wrote 4 pages, got 5 marks, and 1 page got 80 marks. So these are structured essays. I think because usually the students learn from lectures and all. Really, they follow the practice. But when there's a wrong practice, it is more actively followed up, learn from that than the lectures. Our correct practice very rarely they follow. So that is the normal human behavior. Any questions? Any questions? That's all I have to talk about. So I think again the summary again and again. Puna puna summary, puna puna summary. Huh? And the knowledge with understanding make practice rational, and practice make you perfect. Thank you.